And it's for him, for Bryson, it's a lifelong struggle. So she's going to visit us. He'll probably be there too. And Miss LaRoche is going to pop in sometime today to talk about, thank you, whoever started the recording, probably Maggie. Thank you for, or no, yes, thank you for that. Miss LaRoche coming in sometime today to talk about your preceptorship. So she will be here today to answer any of your questions. And then we have 2 presentations before we finish off class today. So we got a lot to do. Any business, any announcements? Okay. Last week, tomorrow's the last day of clinical. If you owe any hours, please get them in. So you don't have to come back next week. Okay.
Just to confirm, it was 6 sessions we had to go see Ryan, correct? 6?
Yes, correct.
Okay.
Yep. If you haven't done your mental health project for Ryan, tomorrow is the last day. So yeah, it went fast, didn't it?
Can you tell us a little about the final?
Sure. It'll be Tuesday. Tuesday, our class finals at 10 a.m. It is going to be on campus on your iPad. So bring your iPad. Then you're free till 2 p.m. when you come back to campus to do the ATI. The final is cumulative. There will be about 70 questions with a particular focus on the chapters that you guys have not been tested on. So help me out. The 3 we do today: children, elderly, sexual dysfunction, eating disorders, OCD. What else have we done since the last test? That's a lot. That may be it. And I can certainly, I'm sorry?
Chapter 15, 20 through 24, sexual disorders.
Yeah, 15 is OCD. I can put all that into a statement for you and post it. I know y'all are getting sick of my postings.
No, great.
Yes, please, that'll help.
Yeah, okay. Yeah, I will do that. So again,
and also you mentioned
Go ahead.
You mentioned something about Sunday night. We're going to have a review. Is that still on? And can you tell us something about it?
Sure. It's actually Monday night. So Monday after you finish your tests, your OBPs or whatever you've got Monday, Patty, the clinical adjunct, is going to do a session from 6 to 8 p.m. on Teams. I'd like you guys to bring questions or any content that you want to go over. And I'm having her do it because sometimes just listening to somebody different, something will sink in that didn't sink in the first time. So just an example, if you're struggling with conversion disorder, bring your questions, and we'll have her go through that and talk about it and ask you facts and things like that. So that's 6 to 8 on Monday the 5th on Teams, and I will remind you about that also. I'll probably send you a invite. It's not mandatory. It's not mandatory, but if you want to come, you'll be studying anyway. You might as well turn it on and listen. Any other questions?
What are the number chapters that we're going over today?
22, 23, and 24. And I did post those in our last week, so you should be able to find them. Just a reminder, and I was going to post this also, but Melissa yelled at me because I had 19 posts on her. So I'm trying to lean back a little bit.
What's up, lady? But this is neurodevelopment disorders. Is that what you're talking about?
Yeah, Absolutely, and I know you read it before you came to class today, so you'll be able to tell me all about it. Neurodevelopmental.
I don't have 50 million things to make up.
Well, use your coping skills now. Deep breathing. And just a reminder, AA, if you have not gotten AA right up in, I think that's due finals week, and your last number 3 clinical log is due, I believe, maybe today or tomorrow or the next day or something like that. Get those in. Make sure you've got everything in.
Friday midnight.
Thank you.
According to my schedule.
And it's the same rubric that you used for the first 2. I just want you to pick a different day and talk about it. Or if you want to talk about picnic project, that's fine too, if you want to do a different one. Any other business? All right, let's jump in. Tell me, I know most people got to go to the children and adolescent unit. What kind of things did you guys see? What kind of diagnosis did you see the kids struggling with?
A lot of depression.
Okay.
ADHD.
Yeah. Uncontrolled ADHD, right? Which sometimes comes out as behavior. What else? Do you see any autism?
Only one.
So technically you're not supposed to Baker Act kids with autism, but they do it all the time.
Wait, was that the 6-year-old?
I don't know, I wasn't there.
He was 12 years old, Francisco.
Oh, well then I think there was a 6-year-old that was suspected autism, but they had just like Baker acted her because she was being weird.
Yeah. How about Asperger's? Did you see any Asperger's? No. Okay. So while we're talking about the kids, just remember, kids can have any mental illness that adults can have. And we're just kind of figuring that out the last 20, 30 years, fortunately. Are our kids sicker? Maybe. Are they more stressed than they were 30 years ago? Maybe. Are we diagnosing earlier? And that's a possibility too. But kids can get the same things adults get. They do present a little differently because it often comes out in behavior or school problems. The one that they don't like to diagnose is childhood schizophrenia. They don't like to put that label on until they're at least 16, 17 years old. There are some cases out there. This is one of my pet peeves. There are some cases out there that claim childhood schizophrenia. I don't know. How do you know that young if it's imaginary friends or bipolar disorder or ADHD? I think it's just too early in life to kind of put that label on. So that's one they try to wait for. But a lot more kids being diagnosed with bipolar, particularly if it runs in families. Hard to get services for kids. You may have noticed that. So when I was working out in Daytona, we would get kids from Jacksonville, way up in the Panhandle. If we were full, we would send them to Orlando. I mean, and that's a long wait for a family to have to travel if your kid needs to be hospitalized. So that's one thing we need, I think, is more inpatient beds or more day treatment for kids. But we're trying. The stigma is still there for kids, just like it is for adults. It's pretty powerful. All right, 22, neurodevelopmental disorders. Neurologically, and you guys know you just did peds, if kids aren't meeting milestones, if kids seem delayed in any verbal communication or any hands-on tasks, they are often labeled. I think we need to be a little more patient with kids and not label them so quickly. It seems like everybody's getting the label of autism very quickly these days, or ADHD. But these neurodevelopmental issues can start pretty young. And when you meet Janice and Bryson today, I'm sure as she tells you her story, they knew right away after Bryson was born that there was something not quite right. So again, the symptoms come out differently in kids than they do adults, because the kid is developing and the kid is changing, and they express themselves differently. But we are seeing disorders like autism very early, into the early months after a child's born. Okay, IQ. Anything lower than 70 IQ is considered below average. We talked a little bit about fetal alcohol syndrome during the semester. That is one behavior that contributes to possibly low IQs or learning disabilities. But again, this is a axis 2. Remember, learning disabilities are an axis 2. So people can have bipolar, depression on axis 1 and still have low IQ on axis 2. So it's going to affect how you interact with them and how they're able to learn. And again, we don't know what causes this. We have a lot of theories. There's a hereditary component, problems with development in the fetus, fetal alcohol syndrome. We talked about drug use, environmental factors. Are the mothers living around toxic chemicals, or the kids growing up with a lot of lead, lead paint in their environment? So those are all things we've looked at. Water, contaminated water. Okay. So the new DSM did some finagling with autism and Asperger's. So what we have now is an umbrella out of the DSM that's called autism spectrum disorder. I don't like it. I don't like a lot of things. I don't like this because it's a spectrum. Just like with schizophrenia, you can have a little autism where it's not even noticeable, or you could be severely autistic. And it's just such a label. That's just my opinion. It's just such a label. And we are diagnosing quite a bit. So autism is the overall umbrella label that we put. But the different characteristics of our autism disorders are very different. So, for example, Asperger's. Kids with Asperger's are usually very intelligent, very smart. They can look at things outside the box. They're very concrete. They are awkward socially. They don't maybe not get jokes, or they don't get, like, if they have a girlfriend and the girlfriend breaks up with them, they just don't understand that the relationship's over. Those kind of social perceptions are very different for Asperger's. But they can be very high functioning. They're very smart. They can learn to deal in this world. They find jobs that meet, what their strengths. That's very different than autism, and both of those are under the same umbrella. So that's kind of where I'm coming from. For the exam, I'd like you to know autism, classic autism, and Asperger's, and the difference between the two. But also know they are all under that umbrella of autism spectrum disorder. Okay, so classic autism. More common in boys than girls. Usually present by early childhood. And again with better assessment techniques, I think we're diagnosing even earlier, sometimes wrong, but we are. The autistic kid is in his own world. They have poor social skills, but they don't interact with others on a constant level. So parents will often say the kid didn't make eye contact with me, or we thought he was deaf because we would call him and he wouldn't even look over here. They play by themselves. So it wouldn't be a kid that goes and engages with other kids in a large like nursery school setting. They'd be to the side. They are extremely sensitive to noise and commotion, which, as you can imagine, a mental health unit is full of. So, as I said, you're not supposed to be able to Baker Act anyone with autism, child or adult, but they do it all the time, unfortunately. When they get overstimulated or upset or can't express themselves, they possibly could have self-harm, head banging. They do hand flapping. This is called simming or simulation. They self-stim. So poor social skills. And again, that continuum. They may not speak. They may not have speech ability. They may not have ability to dress themselves or eat, or it may be a lower level of autism where they do. But they're in their own world, little eye contact, play by themselves. The autistic kids they get focused on topics. So if a kid with autism is interested in Superman, it's all about Superman. It's Superman 24/7. And teachers can use that. They can use that to incorporate Superman into math skills or writing or whatever it is. But they do get focused on areas of interest, and then it's all about that, all about trains or all about Superman. Questions so far? This is a tough kid. This is a tough kid for a parent, because you guys learned how important that connection is after birth, and that that connection parent and child. And the autistic parent feels they don't have this a lot of the time because the kid is in their own world doing their own thing. So where does autism come from? We know there is a genetic link. It does run in families. I have a friend who's a nurse practitioner. Her husband has Asperger's, and her 3 boys all have autism. She has her hands full. You may have studied the controversy in research where the false study came out about vaccines causing autism. It was a false study. That gentleman lost his medical license, ability to do research. But those thoughts still are around today. And, we call them the non-vaxxers. And that group's promoted a little bit with celebrities. But there's still a fairly large group that are not vaccinating their children because of that belief that it causes autism. And if you got to work with any of the immunization nurses during public health, all you had to do was mention that group, and they go nuts in there, as far as people who don't vaccinate their kids. So kids with autism, they can improve. And so one of the goals is to get those special interventions as early as possible: language therapy, occupational therapy, special educational resources. They can improve, but autism persists into adulthood. So you guys will be working with adults that have autism, and just to know that they look at the world differently. There was a case a couple years ago in Orlando where a man with autism, he was out on the street talking to the prostitutes, socializing. And they ended up arresting him for soliciting a prostitute. It ended up being in the news and a big thing. He was not soliciting a prostitute. He was talking in a different sort of way that they interact. And the police officers didn't understand that, and arrested him. So there was a lot of outrage, and I know more police forces, nurses, we're all getting more training on autism, how people with autism present differently, think differently, so that we can deal with them. So behavior, our main goals with this group are behavioral issues. We want to get them the services they need. We want to reduce the behavioral problems. You can read about Rhett's disorder. I'm not going to test you on that. Or childhood integrative disorder. Okay, and then Asperger's is the other one I would like you to know. It is under the autism spectrum. They do not have cognitive or language delays. So remember, they're doing fairly well in school. They're fairly intelligent, usually succeeding the average kid in the classroom. Motor clumsiness is common. They're awkward. Physically, they're awkward socially. And again, I describe it as they have no filter. Like someone with with Asperger's will just tell you exactly what they think. Whatever they think comes out of their mouth. They just don't have that social filter that other people have. Asperger's, again, occurs more frequently in boys. And we do know there's a hereditary component. And we're learning more about Asperger's. There's been a lot of good movies that have come out. So hopefully we're helping this group progress through life. But they find a career that meets their strength. It might be being an accountant or being an engineer or whatever it is, and they function really well like that. Questions?
Could both of them be present? You said it's autism is passed through the genes. So I have I had a coworker. I didn't ask a lot of questions about it, but her first daughter was diagnosed with autism, and when she gave birth to her son, later on they diagnosed him with Asperger's. So both of them had challenges like that.
Yeah, it definitely can run in families like that. Yep. Or even two with autism that have different levels of functioning. And then she might have a kid that they don't see any sort of disorder. Yeah, a lot of research going on. It's kind of interesting. Just some autism related disorders. We're going to talk about Tourette syndrome in a minute, but just know that there are a lot of learning disorders out there. Kids can have motor skill disorders, communication disorders, and elimination disorders, meaning being incontinent of urine and feces. All those kind of fall under the autism spectrum. And Prader-Willi, which we're going to learn about today, definitely falls under this area. So they're always coming up with new disorders and putting labels on them. So if you're going to work in peds, it'll be important to keep up on these. All right, tic disorder. So Tourette's. Tourette's, again, is something like OCD that we kind of laugh at. And I'm saying we as the world, not us. They make a movie about Tourette's and make it funny. Again, like OCD, not a funny thing for someone who has it. So Tourette's can come out as they are tics. It can come out verbally. It can come out as physical tics, and these can start in childhood. Usually continue into adulthood. So again, you have adults with the same behaviors. But think about being a kid who has Tourette's with verbal outbursts, usually swearing. That kid being such a target for bullying or being punished when they really can't control it. Tics wax and wane, like OCD, in a very similar way. When people are stressed and they have Tourette's, the tics will increase. So there are times and there are techniques that the kids can use to control the different tics. But during times of stress, they may come out more. There's really no treatment for Tourette's except for our antipsychotics. They actually use second generation or atypical antipsychotics for Tourette's. And we know all the side effects that come with antipsychotics. So sometimes the side effects are worse than the actual tic. Where you're at risk for tardive dyskinesia or neuroleptic malignant syndrome. So that has to be a decision made with the doctor and the family. But that is the one medicine they're using right now for Tourette's. A lot of people think it's a behavioral thing, the kid's out of control, but it really is a disorder. And if you've ever seen an adult with it, I mean, the same. People just look at them in a store, they'll just look at them like they're crazy. We talked about learning disorders. Just be aware, kids are getting diagnosed in school. Hopefully they're getting the help they need. If you got a kid like this, it is a full-time job being an advocate for them. Just be aware of that. If you're working with a parent where a child has ADHD or learning disorders or or autism, it's a full-time job advocating for these kids. Motor skill disorders would be anything physically that they're struggling with, coordination, being able to complete tasks, even like feeding themselves. And again, open to bullying, open to being different. Communication disorders, obviously the inability to communicate. And you'll see this with Bryson. He's pretty, he's limited with his communication. Sometimes he'll just grunt if you ask him a question sometimes, but definitely affects his life. So speech therapy, very important. Okay, stuttering, we'll just throw it out there. Stuttering is definitely a disorder that's been connected to anxiety. Can come and go in children or adults, but it is a real thing. It's embarrassing for a lot of people. People come to treatment to try to work on that. All right, elimination disorders. So again, bedwetting is normal to a certain age and higher ages in boys than girls. But if kids are still wetting the bed, early teens, or intentionally wetting the bed for behavior or defecating somewhere, then it gets to be the extreme where it's a problem with, they call it elimination disorders. You'll see with some of these kids that have neurological issues that it might be defecating in the corner and then, just like painting. I'm sorry for all of you that just ate. There's painting with the feces on the wall. Some of those behaviors are not uncommon in the autism spectrum. So that we ask these questions. We ask, are they able to get through the night dry? Do they wear diapers? All those things. Any questions before we get into ADHD? Okay, ADHD. So we have two types. We have ADD or ADHD. The ADHD has the hyperactivity connected to it. So you could have attention deficit disorder and actually be very quiet. Just sit in the classroom, nobody kind of notices you, but you're in your own world and you're not able to focus. ADHD has the hyperactivity connected. They are all over the place. And if you were able to see that at the hospital, you know what I'm talking about. Pretty common diagnosis. We had a lot of issues with teachers kind of coming out of, I'm sorry, teachers, but teachers coming out of their scope of practice and telling parents they should get their kids tested, that this kid's got ADHD. But we have to remember that the behavior they're seeing in the classroom may be connected to other things. It may be connected to stress, anxiety, anger, sexual abuse at home, or it could even be bipolar that's misdiagnosed. So it's important that kids get a good full assessment from a professional. But kids with ADHD, they're inattentive, they're all over the place, extremely impulsive, and more boys than girls again. Usually pretty noticeable once a kid starts school, kindergarten, first, second grade. And sometimes they do fine at home. If home is not particularly structured, a kid with ADHD may do fine. But in a classroom setting, it's just torture for them. Kids were not, this is just my opinion, you won't find this in the book, kids were not made to sit at a desk for 6 hours. You know, so teachers who are doing some really creative things to keep kids involved, using the yoga balls to bounce on, or being able to get up and move around and do hands-on learning, all that stuff is great for someone with ADHD. Just sitting at a desk is torture. But impulsivity, blurting out answers, it could come out, their frustration could come out as anger, aggression in the classroom, and then never having their homework done. And again, they're very much at risk for being called out for their behavior, sent to the principal, bullied because they don't fit into whatever a normal kid is. And even when they're on medication, that kid knows he's different. The kid knows he's taking medicine to keep him calm. We don't know where it comes from. Again, we know there is a hereditary genetic link. The researchers have looked at environmental toxins or things related to prenatal development, but we really don't know. There is a part of it that is also personality. You know, is it somebody who's, I don't want to say acting out, but pushing the limits? They may not have structure at home. If they've never had structure at home, obviously they're not going to be able to sit for 6 hours and be quiet if they've never had to. So some of it, there is a family component to it. That's why it's so important for the schools to work with the families and the families to work with the schools. Risk factors. Kids with ADHD are at higher risk for drug use later in their teens. My question always was, is it because they want to be part of that peer group? They need to use drugs to feel like part of a group? Or is it the fact that we've been pushing drugs on them since they were 4 or 5 years old? And it's just common behavior to use the substance. Every time we put that Ritalin or Adderall into a 4-year-old or a 3-year-old, their brain's developing. So we really don't know what we're doing to little brains. And we may not know for a lot of years. So a lot of medication. Absolutely, go ahead.
I just want to interject something that I'm seeing, and it seems to be prominent, is that these people are winding up in addiction recovery. And I'm seeing lots of them saying, oh yeah, I was on amphetamines and now I'm here in recovery.
Yeah. There's something to it. You see what I mean though, Steve? Is it because we pushed taking drugs because it's normal, or do they're really trying to be part of a group? It's kind of it's interesting, but we need to do more early work to prevent that from happening.
My feeling about it is that if we could figure out if they're addiction prone or if they're let's say a high risk for addiction, they shouldn't be put on a med like that. In other words, if the parents are both addicts and the child is likely to be one, then a medicine like that is very risky to give to a child like that, because if they become an addict, they're going to wind up in treatment for it.
Yeah, and they're not light medications. That is true. And I'm talking out the side of my mouth because I medicated 2 of my kids with Ritalin. And I probably wouldn't do it again. But I made that choice at the time. I don't know if it was the right one. Both of them were great cheekers, so they hardly ever took their meds. But it's a very personal decision that needs to be made with the doctor. And unfortunately, you get teachers pushing, doctors pushing for meds, and it's not always the answer, I guess is what I'm trying to say. They can learn techniques. Again, I said home and school need to be connected. So a lot of places will have a report card from school, a daily report card that goes home, and then home sends a evening report card back to school, so that everybody's doing the same thing, using the same rewards, consequences. So home is not much different than school as far as expectations. We're trying to change behaviors. These kids need a lot of creative play, a lot of therapeutic play. They need to be able to move around. They need to be able to be themselves. All right, so how do we treat ADHD? Stimulants has been the, I guess, most common. They're trying to get away from stimulants. Prescribers are trying to get away from stimulants a little bit because of the addiction component and the abuse component. So as you know, if you have ADHD, this is not news to any of you. If you have ADHD and you take a stimulant, it actually calms you down. If you do not have ADHD and you take a stimulant like Ritalin or Adderall, it speeds you up, helps people study, helps people focus, get a lot done, lose weight. So obviously, drugs of abuse for some people. They're moving away from it. So they're using some antidepressants. They're using an SNRI, which is a non-stimulant. Out in Daytona, one of the common ones, the common combination they're using out there, and you guys may have seen it in Seminole County too, but they were using risperidol, which is an antipsychotic, and Intuniv, which is an antihypertensive. Something about the combination of those two was helping the kids with the ADHD. But you're giving a kid an antipsychotic now and an antihypertensive. So you're monitoring blood pressure, you're monitoring for extrapyramidal symptoms. And I had a real hard time with that, getting consents from families. I would have them look up those 2 meds, risperidol and Intuniv, read about them. It's not like Ritalin. No, those are 2 meds that are being used for ADHD, but they don't have the same side effects. Clonidine is another one that they're using. Clonidine will help also if you have a bedwetter, somebody who can't get through the night with being continent. Clonidine helps with that. But again, with these antihypertensives, you're checking for orthostatic blood pressures. Kids can get dizzy. Okay. When we're doing assessments, it's important to get that full life assessment. And some of these parents will tell you the kid was always fussy. The kid was always a handful, always out of control. Couldn't sit still. A lot of bipolar is getting misdiagnosed as ADHD. So that's something we have to be careful with too. If it's bipolar, a stimulant is the absolute wrong medication for that. Kids with ADHD, a lot of frustration. A lot of anxiety, being different in the classroom, could agitation, they may act out, they may be violent. And actually, a lot of the Baker Acts connected to ADHD are kid hurt somebody at school, punched grandma, whatever it might be. There's some sort of violence or aggression that's coming out from that frustration of the disorder. So it's not a bad kid. We can't go to that bad kid. They're struggling with something, and losing control. We got to help them with that. That impulsivity is huge. They don't think before they act. They put other people at risk physically. They may run into the road, run out of school, put themselves at risk. So their insight and judgment is poor. Very low self-esteem for this group. Obviously, they're going to have social and academic problems with all these things we're talking about. These kids just, if they're struggling, they just don't fit in. And even if they're medicated, there goes little Billy to the nurse's office again. He's going to get his pill to calm him down. Emotionally, what does that do to somebody? Self-care may be compromised with the inability to focus on a task like brushing your teeth. The one thing that these kids on stimulants, which is very common, is they lose their appetite. So weights, not daily, but at least weekly weights are important if you're a school nurse. Making sure the kid eats before he takes his dose of Ritalin, because it's going to take his appetite away. You don't want kids losing too much weight. Again, risk for injury. We don't want to hurt anybody else to get hurt. We don't want the kid to get hurt. Lots of family education, very important. The daily structure is important for a kid with ADHD. And you guys may have wondered why in the children's unit, the adolescent unit, they were so structured and so strict on the rules. And that's one of the reasons. With this group in particular, you can't change the rules a lot. It stresses them out. That changing stresses them out. They need to know what to expect, what's expected of them, and to meet it. Just to mention, I saw animals there. The triad of children and adolescent psych. If you see these three things: aggression towards animals, which is more common than you would expect, and it's disturbing, fire setting or bedwetting. So animals, fire setting, bedwetting. If you see those three in a child, run. Those are signs of antisocial personality disorder of adulthood. Those are signs of a sociopath. So if you have all three of those together, we call it the triad.
I'm sorry. It was towards aggression towards animals, bedwetting, and what else?
Fire setting.
Thank you.
A lot of kids take out their frustrations on the family pet. And that could be a cause for a Baker Act too. Important to involve the family, important to involve everybody in the school, definitely interdisciplinary. And you guys who were there, you saw there is school in the mental health facility for the kids. They feel like, oh great, I'm Baker acted, I get out of school. There is a teacher there. It's not traditional school, but it is definitely, they're trying to keep them up with their studies. The other group you'll see quite a bit on the children and adolescent unit are these IB honors kids. That really shocked me when I first started working with this group, because we learned about ADHD, we learned about behavior, but it was like towards finals and midterms and stuff. These kids, the stress, they would just fall apart. They would get depressed, they would get suicidal. So that surprised me when I started working with that group. Any questions on 22?
You didn't say anything about etiology for ADHD.
Genetic, and they possibly environment, possibly behavioral patterns, how the kids were raised. There's a little bit of that. They don't quite know. And again, these aren't stupid kids. A lot of these kids are brilliant. They're brilliant kids. They don't learn the way that we're telling them they should. By sitting at a desk, you know. People, they can learn strategies. Sorry, I'm trying to find the next chapter. They can learn strategies for learning. It might be listening verbally or having a one-to-one tutor. There's a lot of things that we can give them to help them. Often it goes undiagnosed and it's just, we call it, you know, it's the bad kid. That's the kid that's always in trouble. But a lot more ADHD than, you know, there was 40, 50 years ago. Is it just that we're diagnosing, or, you know, is there something in the environment or the world that's changed? I mean, when I went to school, they didn't have, I don't think anybody took Ritalin. We just, you know, there was a bad kid that was always in the principal's office. Okay, I'm going to pull up chapter 23. And we're going to talk about disruptive behaviors. Give me 1 second. I want to text Professor LaRoche and see where she is.
I think she said she was coming on at 2:30
Okay. How do you know that?
because she sent an email. She sent us an email.
Okay.
She sent an email too that she needs the link. And the
Oh,
link she went to was not a class. So I'm trying to send it to her now, but if someone else knows how to do that,
I already sent it to her.
thank you.
I figured somebody.
Same.
Thank you.
She's probably gonna get a million emails.
Thank you. Actually, I think I can just call her in, but we'll see. All right, now she's saying 2 o'clock. Hang on. Hate when things change. So everybody's texting her, nobody was listening in class, right? You guys are going to miss me someday. You're going to be like, I wish we could go back to mental health and I could listen to Dr. Green.
I'm right here, Professor.
Or maybe not.
You, yes, not the material.
Oh. Okay.
I'll miss you.
Thank you. Thank you. Never say goodbye because you never know. One of you might be my boss someday. Who knows? Okay, let's keep on going. She'll let us know. I said 2:30 and then she texted back and said 2. All right. So disruptive behavior disorders. Obviously, this is exactly what it says. Kids are acting out for some reason. It could be aggression, it can be verbal hostility, it can be breaking property, it could be, you know, they hurt people. But they're expressing themselves by the acting out behavior. There's 3 you should know. You guys can see the slides, right? Yes?
Yep.
Okay.
Yeah, I've seen him.
Yes.
Thank you. That's when people go from 0 to 100 with their emotions. They're triggered by something, they get upset, and they're off. They're into a rage where they hurt somebody, road rage may happen, or pull a gun on somebody, whatever. This can happen in children and adults. We call that IED. Oppositional defiant disorder. This is a group of kids who don't like following the rules. So this is kind of an early antisocial personality. They may bully other kids. They may steal. They may get in trouble. They're oppositional to authority, teachers, police, nurses, whoever it may be. So conduct disorder is similar to ODD, but it's more extreme. So think of those two as a leveling up. So you'll see kids diagnosed with ODD. Conduct disorder is usually more severe in the behavior. It's been around longer, and it's usually with the adolescents towards the conduct disorder is usually with the teenage kids. When they're getting involved in courts, family courts, they've got charges already at 15 years old. Skipping school, drug use, they're pulling these kids out of drug houses, and you'd be surprised the stuff that they get into. So does that make sense? ODD is a lesser level. Conduct disorder is more severe.
Now, is there like anything in particular from both of them? Because I feel like sometimes when like on the test questions, like right now, I could tell you from what you just told me, I could differentiate both of them. But when it comes to the test question, you might ask something beyond that might be like, well, it could be this one, but it could be, this one as well. Like the ODD could be a 9-year-old, but he's already manslaughter or something. And you're like, well, is that an OD? Like, I don't know, so
So let me give you an example, Michael. So ODD, but might be that 9-year-old, a little younger, talking back to the teacher, maybe stealing a pencil off his peer's desk, just being defiant in a quieter kind of underlying way. Conduct disorder, think older adolescent, legal charges, running away, drug use, more extreme on the behaviors. Does that make sense?
Yeah, got it. Thank you.
Mm-hmm.
Dr. Green?
Yeah.
Last week we had a patient who was 6 or 7 years old. It was the one that me and Kiyomi had in the adolescent side. Do you remember him, Kiyomi? He had in his chart, it said conduct disorder. And it's like he was only like not even 7 yet. And the nurse said that he pulled out a knife on his grandmother, and she's his caretaker. So does that, like, that's more severe than oppositional? So if he's that young, then like does that mean like he's going to be like an antisocial personality, like, sooner than like most other people? Because that's like pretty crazy. You wouldn't be able to tell by looking at him or interacting.
There's a pretty good possibility he's going to be sociopath or antisocial if he could pull a knife on grandma. So yeah, you're right. I mean, like a lot of the time they'll just label it ODD, and then after they see it for several years, it'll go to conduct disorder. But if at 6 years old you're pulling a knife on family members, yeah, they're going right to the big one.
And he probably something else mixed with the ODD, because when we were talking to him before looking at his chart, he was just super sad and just uninterested. So we were thinking like mood disorder. Mm-hmm. But then when Mira got his chart and it said that, so could they have a plethora of things going on?
Yeah, oh, absolutely. So that kid could have had depression, bipolar, and all these other things. Absolutely. And these are axis 1. So yeah, you can have.
He was really sad. He wanted to go back home to grandma and his siblings, but he pretended like he did nothing wrong or nothing happened. So it was just really interesting interacting with him.
No remorse, right?
Yeah.
And he probably was so sweet. Was he like a sweet little kid? I know you.
You would never have guessed.
You hear these stories, and it's like broke grandma's arm, and yeah.
Yeah,
We're
he's
calling.
been there multiple times because I asked him. I was like, "Oh, have you ever been here before? Or have you went somewhere like this?" And he was like shaking his head. I'm really sad.
Yeah, I know. And then we get kind of like, what are the parents doing wrong? There must be something wrong at home for him to act like that. We want to save them. I think Miss LaRoche is with us.
I'm here. Oh my goodness, it's been a road trying to get here. Y'all see that I'm in my car, so don't mind me.
They're ready for you.
I know. Okay. You guys hear me okay?
Yep.
Yeah. Okay. Yeah. Good. So I know I sent you the really long email that covered a bunch of the questions that I typically start hearing at the end of the third quarter. So if you had a chance to go through that and just kind of read what the process is, you see that it's kind of like a whole big waiting game. You have to wait, and then hurry at the end. So after reading the email, does anyone have any questions about practicum in general?
I had a question about the location. So it says ORMC, and then it says like UFHCC, and I was wondering, is UFHCC the 10LP the colorectal floor?
Not just 10LP, but the tower that 10LP is in.
Okay.
I don't actually think it's called UF Health Cancer. I think Orlando Regional has completely bought them out, and I think it's going to be just part of ORMC.
Okay.
But the reason I separate them, you'll see on the wish list, is because there's certain people that specifically want oncology, and that's a special kind of nurse right there. You know, it's a specialty, and if that is not your thing at all, I for sure don't want to put you there. You know, people have personal experiences and whatnot, and they don't want to be on an oncology unit. But if that's your jam and you want to do that, and I know, then I'll put you there rather than like a med-surg floor at ORMC. So you might still be getting just med-surg patients, but then if there are oncology patients, you would get them, where you wouldn't get them so much at the main tower in ORMC.
Okay. Yeah, I was just curious about the difference between like ORMC and that one.
Right. That's it.
Okay. Thank you.
Anyone else?
When and how do you want us to submit our preferences?
Okay. When's the next time you guys are on campus?
Monday.
Monday.
So at what time and for what exam?
10 for OB.
10 o'clock. Okay. So what I can do is I can just leave a stack. I'll be there Monday morning, but I know you guys will finish at different times. So I will leave a stack of the wish lists. When you guys are in your exam, I'll leave them in the lobby on the desk, and then you can just grab one and fill it out and either give it to me or leave it on Dr. Trainer's shelf. Okay. So let's talk real quick about the wish list. So it's got a bunch of different locations. I think there are a couple added that weren't on the email that I sent to you. And inevitably, some of those places don't give me any spots at all. So you might actually last time I had someone, their top 3 choices, we didn't even get any spots at all. So if they don't tell us they have spots, we can't assign anyone there. So with that being said, think about it. Winnie Palmer is on there, and it's a specialty area that I know a lot of people want, as is Arnold Palmer. Typically, we do not get spots for Arnold Palmer. Last time we did, because there were so many like med-surg type nurses at ORMC and other spots that were displaced because of COVID and or training new nurses, that they didn't have enough preceptors for practicum students. So they ended up having to give us a lot of specialty areas that we don't normally get. So while I'm not going to say there's no chance that you're going to get Arnold Palmer, if I have 15 people, and that's not uncommon, that have Winnie Palmer as their number 1, Arnold Palmer is their number 2, or vice versa, and then ORMC is their number 3, those are the 3 top choices all the time, unless you live like right next door to one of the other hospitals. So it says, give me your 1 through 3. You can number them all in order if you would like to. It won't bother me any. You can, if there's 10 choices, you can do 1 through 10, whatever. So I'll just go down the line. The person that didn't get any of their 3 choices last time, I just called them up and said, what would be your next choice? And that's what they got. So not counting that person, I'd say 95% of the time, if you don't put Winnie and Arnold as your top 2, 95% of the time I've been able to give students either their number 1 or their number 2, occasionally number 3. If I can't give you your number 1 or number 2, I'm definitely going to try to honor whether you want day shift or night shift. There's going to be a spot for if you prefer day shift, night shift, or no preference. And I put on there that you can choose 2 of those options, meaning, let's say you really, really want night shift, but you don't want to give up an opportunity for that reason. You'll take day shift if it's in one of your top locations. Then put night shift and no preference. So the people that strictly put just day shift or just night shift, and that might be you for work reasons or childcare reasons, whatever your reasons, there may be a time because I can only place students where we have spots. You're not necessarily guaranteed to get your day shift or night shift spot either, but I try my hardest, and I've never not been able to give students their preference. So if you truly have a reason that you cannot do one or the other, just check that one. But if you're kind of flexible, but you really want one or the other, check both of them. Because sometimes it'll come down to, like, if you put just no preference and let me choose for you, maybe I have the same unit with a day shift and a night shift spot open, and I don't know which one you really would rather have. So I'd rather you tell me either day shift or night shift and no preference. If you really, really don't even care, just put no preference, but usually people care. With that being said, I've heard some people talking or emailing or asking me about can they find their own practicum placement. And the school has said that the students are not allowed to do that. It has to go through the student coordinator. Coordinators are the educators at the other smaller hospitals. So I'm going to request spots at all of the locations, and they'll tell me what units are available according to how many preceptors each learning specialist or educator has available. And then we'll go from there. So if you really wanted a mental health option, that's an area we don't typically get to place students in. I know last cohort 25, there were a couple of students who really, really wanted mental health and didn't get mental health. And with that being said, one of those students got hired into the behavioral health unit. So just because you don't get where you want to work, it's only 12 shifts. Sometimes it's used as a stepping stone. Many times it's used as a stepping stone if you're in a unit you want to work in. Or sometimes you're in a unit you don't realize you want to work there, and then you find out you want to work there. You like it so much. But that's not the main objective of the practicum. So the main objective of the practicum is supposed to be to help tie up loose ends and put into practice what you've learned in all your didactic and your clinicals. So in order to prepare you for your NCLEX, because, you know, if it's something that you read about or were lectured to about, it's not going to be as impactful as if it's something that you've actually done in the clinical setting. So if you really want to do cardiac ICU and you're in cardiac ICU and you have a bunch of questions about GI bleed and GI issues, you might not have experienced that in practicum. Whereas if you're in a unit that's more broad and has more diagnoses, then you'd have a better chance. So I'm also not going to say we're not using specialty units, because right now with COVID, we just don't even know what we're going to get. We had to put about 15 people in cohort 24 in ICUs and emergency rooms and all the places that we say we don't normally use. They went to. So it's not unheard of. Dr. Trainer asked me this morning if you can write down what field you're interested in or what type of unit. Again, I don't mind. Sometimes it's helpful for me to know what you hope for, what kind of unit you hope for. But if you do that and someone gets the unit that they hope for and someone else doesn't, I really don't want to have to field a bunch of complaints because some people got their unit of choice and other people's didn't. Other people didn't. That's why the school took that option off the wish list a while back, because people felt there was favoritism, and that wasn't the case. But if everyone wants to write on there what you really want to do, I don't mind. I will try, like I said, I try to accommodate everyone, but it's virtually impossible to do that for
I have
everyone.
a question.
Yes.
How do you how do you go through the list about who gets placed where? Is it by like alphabetical, or is it by GPA? Because we've heard like different strategies.
So in general placement, it really doesn't matter where you're at. If you're wanting a specialty unit, that's when that academic standing, so to speak, would come into play. And the rationale behind that is, like I said, this is supposed to be to prepare you for your NCLEX. So if someone was very strong in med-surg, got an A or a really high B in their med-surg class, and did well on the med-surg ATI, which I get the scores, I get those reports from Professor Stevenson, then we're not so much worried about whether or not they'll pass the NCLEX, as opposed to someone who has a lower GPA, barely squeaked by in med-surg, like that, you know what I'm saying? And it's not always the case. We have had, like I said, cohort 24 and some of cohort 25 they were placed in units we would not normally put them in, and they had like a 98 or 99% NCLEX pass rate. So not always the rule, but that's the rationale why we even look at the academic standing, is just to help you get the most out of the experience, the most broad experience, to prepare you. Okay, so on the wish list, there is a question that says, if your eligible, would you want to work in ICU? And that's on there because in the past, I've had a 4.0 student. I've had two of them, 4.0 student that got an A in med surg, did great. Back in the day, it was HESI and then ATI, but they didn't want to work in ICU for their practicum. So I don't want to put anyone there that doesn't really want to do that. But if I have to use ICU, I want to know, if you had the chance, would you want to go there? Okay.
I have a question too, sorry. I know that you mentioned some of the locations being as far as like New Smyrna Beach and Deltona. Do you take into account where people live? Because some of that is
I don't
really
look at where you live at all. That's why you're given the choice to pick which location.
okay.
So whereas, clinical groups, like for cohort 27, clinical groups were made based on what zip code they were in. When I do your practicum, I'm dealing with the spots that they give me. So whatever I have available is where I have to place. So if I get 15 spots in Deltona, DeLand, Daytona Beach, Port Orange, New Smyrna usually doesn't answer. So unless someone really wants to go to New Smyrna, I'm not going to hound them about it. Advent Health New Smyrna. So again, it's only 12 shifts. But if you put your top 3 choices, chances are you'll get one of those. So that's something you'll consider when you make those choices.
Okay, thank you.
You're welcome.
When you're saying 12 shifts, can you describe, is that over 6 weeks? And what other classes do we have during that period?
So the very first day that you can work a practicum shift is the Saturday of week 6. And then the last shift you can work is July 3rd, day shift. So it actually only works out to 5 weeks because you don't have shifts. You're not going to work shifts during finals week, which is week 12. So typically your full-time people work 3 shifts a week over 5 weeks. That's 15 shifts that you'll have to pick from. And you'll go through, when you find out who your preceptor is, there are 12-hour shifts. When you find out who your preceptor is and you talk to your preceptor and you get their schedule, let's say you get their schedule on a Monday and they're working, let's say if you get it Monday of week 6 and they're working that Saturday, then you work their schedule. So you'll go through all their scheduled shifts and you'll tell them which days you can't work because of exams. And then you'll see how many shifts they have left, see if it's enough for you to get all of your shifts in. Sometimes they don't have their schedule yet that far in advance. So you're just going to be playing it by ear because we can't make them make their schedule earlier than they normally do. So inevitably, someone was only going to have a week or 2 weeks worth of shifts to look at to see if they're going to be able to get enough shifts. I've never had a student not get enough shifts. So it's 12-hour shifts total. One of those is going to be with a nurse leader. So only 11 need to be with your actual preceptor. The nurse leader is the leadership shift. You're going to observe someone usually in a charge nurse role or assistant nurse manager or nurse manager, but normally people get more out of the charge nurse or assistant nurse manager role than they would following the nurse manager for the day. So in the syllabus, it outlines which shifts you need. So when you're planning your shifts with your preceptor, you'll let your preceptor know that they need to set up with your corroboration the shift with their nurse leader. Okay, so you don't want to go around to the charge nurses and say, hey, I have this shift I need to do. Can I do it with you? You'll let your preceptor know when you can do it. It doesn't have to be on a day that your preceptor is scheduled. So let's say your preceptor is going on vacation for a week, or at the end of the week, or they only have 2 shifts 1 week. That would be a great week for you to do your leadership shift, because it doesn't have to be with your preceptor. It doesn't even have to be on your assigned shift. So if you're assigned a practicum preceptor on night shift, but there's someone available on day shift and you want to do the day shift for the nurse leadership shift, that's okay too. All right. Steve, does that cover your question about the shifts?
I'm still not sure what classes we have though. Then I know we got our preliminary schedule, but you know, it's like still unclear because then they were saying, well, it's only 3 geriatrics that we do in the first 6 weeks. So during the last 6 weeks, what classes and exams do we have?
No, but I don't believe that you have any classes at the same time as your practicum, because you're expected to be working full time during your practicum.
Okay.
So, but there are exams during that time. Typically, I recall there being leadership exams during your practicum or ATIs. So your schedule will have to work around those exams as well, but no actual class time. So Gero and leadership are for the first 6 weeks of the quarter. But then I believe the ATI and maybe the final exam for leadership for Gero are during the last 6 weeks.
I have a question. So, so hopefully, or by Monday, just to clarify what you said, we're going to write on our wish list the top 3 places, as in, let's say med-surg, ICU, or ER, for example. So we just write that down, and then you're going to look upon to see which one's available, and then you're going to place us at the hospital that you have open, not necessarily where we're closest located, correct?
Not correct. So the wish list is the location that you're going to number 1 through 3 or 1 through whatever are not units or unit types. It's hospitals. So ORMC, Advent Health Orlando, Advent Health Fish. You're going to tell me the location that you want, not necessarily the units. I never know what units I'm going to get. So I would never be able to base you based on what unit you want. So when I go through and I sort through everyone's papers, when I get them back on Monday, I'll sort through and I'll put, okay, I sort them by your number 1 choice, because I'll try to go by that first. So I'll put piles for every choice. And let's say, you know, these people want Advent Health Fish. Let's say there's 3 people. Then when I get the spots from Advent Health Fish, those 3 people will get to go to Advent Health Fish. So, and then when we get to like ORMC, it has the biggest number of spots that they give us and the biggest number of requests generally. So I'll fill in all the smaller hospitals, or if someone, let's say if someone wants number 2 is Advent Health Fish, number 1 was Winnie Palmer, probably going to go to Fish because you're still getting your number 2 choice. Or it could be any combination there. You know, if we have 30 people that want ORMC as their first choice, but their second choice is Dr. Phillips or something like that, some people might get Dr. Phillips because it's still up there in their choices. So then I try to go with what location you want. And then I look and see what units are available at that location that you want on the shift that you want. There's a lot of factors.
Okay, thank you.
You're welcome. So I'm not going to go through every assignment that's going to be part of this because we don't have time for that, but I'm just going to give you like an overview. There's not a lot of assignments. There's a weekly assignment. It's a journal reflection. Super simple. You can't mess it up. There's even a template that's going to be in Canvas, and it's based upon what you've done in your practicum shifts. For example, it's like something that I learned, a new skill that I got to practice, something that made a good or bad impression, and what was it? Something I'd like to do differently or do on my next shift, and then my takeaway for the shifts. So there's 4 of those assignments, 1 due week 1 through 4, and those are 10 points each. And it's really, there's not really any requirements of how much you have to write for each thing, as long as you answer each of the sections on the template. And you can type it right on the template and just fill in the blanks. So that's pretty simple, but it's really just supposed to be a reflection. You're going to have a practicum instructor assigned to you. We usually, for a class your size, there probably will be 5 instructors, 4 or 5 instructors. And before COVID, they used to go to the clinical sites and see you and visit you with you and your preceptor. They're not going to be with you all the time. They're just someone that's going to be evaluating midterm and final. And if you have questions, that's who you contact first, is your assigned instructor. When you get your assignment, you'll get all that information as well. So those instructors, now that there's COVID, we've been having to do these visits virtually. So they have even less contact with you than before. So they really want to know like what's going on. So it's really just a true reflection of what you're doing. And then when you do the section that says something you like to do differently or want to do, that kind of helps you set goals for your next shifts. Makes you think about stuff that you didn't get to do, or maybe you could have done it, or hey, next time I do this, I want to do this. So kind of gives you some direction for what you want to do in your upcoming shifts. So those are those assignments. When we probably, let's say week 5, I'll be coming to your class again once you guys have access to the syllabus and all that. I'll be coming to one of your classes again, and we'll go through the syllabus in detail and answer any additional questions. The next assignment I want to touch on is the leadership observation recording. That's a paper that you'll write based on your observation shift of your nurse leader. Also, it's a guided essay type. There's questions in the syllabus and in the rubric that you'll have to answer, and they're pertinent to what your nurse leader was doing all day and what you learned from that. Usually this leadership shift is a real eye-opener for most students, because most students and most nurses, even on the units, have no idea what's really entailed in being a charge nurse unless you've done it. What you think they do probably is probably just the surface of what they actually do throughout the entire night or day. I was a night shifter. That's why I always revert to night. So like I said, no required number of pages. They're typically 3 or 4 pages long, and specific questions that you'll answer. And then the final clinical self-assessment paper is the CAPS grant. So this is the big paper at the end.
Can you repeat that again? You cut out.
Till the end. So when it says it's due, so this is a self-assessment of what you've learned the entire program. Or VSIMs or whatever you've learned. You actually could start writing the paper week 1. make the mistake of thinking, and I say this to every cohort, they think that they have to do their practicum shifts and write about their experiences during practicum, but it's your whole program. So that it's based on the program outcomes, which are all listed in the syllabus. And then in Canvas, I have a document that's a list of the program outcomes that gives. Can you guys hear me okay? Dr. Green said I'm breaking up.
Yeah, he's been breaking up really bad for like the last couple minutes. Probably.
I'm not sure why. Can you hear me now?
Yeah, we can.
Yeah, now we can hear you.
It's okay. All right. It still says I have full connectivity. Okay, so you can start writing the paper right away, and the specifics are all in the rubric. If you have any questions, you can look at the document in Canvas. Like some of the program outcomes, you've seen them all. It's what you're evaluated on your clinical evaluation sheets. All the program outcomes are in there. So, you know, a lot of them are very wordy. Like you use the arts and letters, this and that in your practice. So in the document in Canvas, I have each of the program outcomes and examples of what you might have done in your clinicals that will help you fulfill those program outcomes. Like, yeah, you know you did all these skills, but you might not necessarily know how they fit in with the program outcomes. And the whole point of your school is to fulfill those program outcomes, right? To become a nurse. So that paper, you have to write about all the program outcomes. It's a graded paper. There's no required length. As long as you fulfill all of the sections, then it'll be long enough. It's typically 8 to 10 pages. So if you're at 2 pages and thinking you're done, you're probably not. If at any time you have questions about things that you're writing or things you should be writing about, your practicum instructor will be able to assist you with that. Basically, each program outcome, you're going to write examples of your nursing care that you did in clinical or in practicum that fulfill that program outcome. You're going to give several examples that fulfill each program outcome in that outcome section. You're going to tell your strengths in the area, what you think your weaknesses are or areas to improve, and your strategies on how to improve. So you can kind of gear your thinking in practicum, like gathering your own evidence by your experience. Like if you put in an NG tube and go, hey, I did really well with that, I'm going to be good at this. Or if you're good at therapeutic communication or whatever, you know, that's make note. You can write about those things. Take notes for yourself for this paper. If you, your hands are shaking like crazy when you go to try to start an IV is generally most students' weakness right when they get out, because very rarely do people get enough opportunities in practicum or clinical to feel proficient. So, but you can make note of those things and just say, you know, this is one of my weaknesses. One of my strategies to help improve this, I'm going to ask my preceptor if we can go to pre-op and start IVs for 4 hours or whatever. You can be thinking that. And then you write about it in your paper. It's something that you've actually done. Okay. Like I said, I'm going to come and we're going to talk more in depth about everything once you've had a chance to look at the syllabus and write down any questions, look through the assignments and the rubrics, look for any of my typos, stuff like that. The only holiday where you have days off that falls during this practicum is the 4th of July. And so it just happens to fall in the right place for where your shifts should stop. So day shift on the 3rd can work. Night shift on the 3rd, you can't work because that goes into the actual holiday on the 4th. Okay. I'm not sure who the instructors are going to be yet. That's a question that I always get because I know everyone has their instructors that they like working with, but they're going to be the instructors that you already know. Occasionally you'll get one, like maybe an OB instructor that you haven't had before or something like that, but all the instructors that do practicum are instructors that you've had already. Especially with doing virtual visits, we used to make their assignments where like Dr. Kelman or Professor Kelman would like hers at ORMC because she works at ORMC. Well, we were doing virtually, so she had some at ORMC, some and like Fish, so they were all over because she didn't actually have to go there. No. So I won't know. I'll make your assignments first and then on the same day. So when I say first, the day Orlando Health gives me the available practicum spots. And last time this was at 5 p.m. So I was up the entire night making cohort 25's practicum assignments just so I could get it to them the next day because the next day they were going to be on campus. So the day I get Orlando Health, I will have gotten everyone else's before that. Orlando Health is always the last one because they have the most digging to do. Sandy has to wait for all the learning specialists of all the units and all the facilities to answer her and tell her what units and what shifts are available for based on their preceptors. The good thing is for you guys, this quarter starts on what, April 19th? Fourth quarter, April 20th, we have our PAC meeting with all of our clinical partners. And so that's where all the educators that I usually deal with are the student coordinators or facilitators that I work with to get these spots are generally all present at this meeting. So Sandy will be there. And if I tell her, you know, she kind of gives me a heads up and says, you know, I've got 35 spots already. She starts earlier than everyone else. After the PAC meeting, she got on the phone and called all the learning specialists that she hadn't heard from and got an additional like 40 spots or something like that. Ridiculous. That was not during COVID, but just saying. It's just good timing for our PAC meeting to be the second day of the quarter. So hopefully we won't be last minute like cohort 25. When can you expect this assignment? Like I said, it's going to be waiting and waiting and waiting and then hurry up. So when I say that, I mean, you can start on Saturday of week 6. You might get your assignment Friday of week 5 or maybe Monday of week 6. So you'll have like, I usually try to give a week or 2 weeks if I can, if they cooperate with me, for you to be able to get a hold of your preceptor. They don't necessarily give me the preceptor's names. They just give me the unit, and then you have to contact the learning specialist to find out who your preceptor will be. So ideally, I would like to give you your assignments and let you have 2 whole weeks to try to get a hold of the preceptor, but it's all based on when they get the spots back to me. Like I said, I'll get the assignments made like that day or that night. I'm a night person still, a night owl. I work night shift for almost 20 years, so it's no big deal for me to stay up and do it. So I just want you guys to know as soon as I get those assignments, I can get them to you. All right, any other questions?
I have a question. If we've only basically been to like Orlando Health and like our second or third option ends up being like an Advent Health location, is there like a credentialing we have to do like ahead of time to like get into their system? Like, will we have enough time for that?
So, yes, you will. So, typically the people that end up going, the hardest one to get the credentialing for is Advent Health, Orlando, Winter Park, Altamont. Orlando Health, you all have badges, you don't need to do anything additional for any of the Orlando Health facilities except for Health Central. So if you end up going to Health, it's just paperwork, and that's usually processed pretty quickly. You don't have to like go anywhere and get a badge. I send them your photos. They have your badges waiting for you, or you meet up with the educator at Health Central on the first day, or whenever's convenient for you to pick up your parking pass and your badge. The outlying Advent Health, the ones east of the school, so Fish, DeLand. We haven't contract with New Smyrna Beach. Like I said, they hardly ever answer me, so it's probably just going to be Fish and DeLand. It's just a matter of paperwork, and they'll get you credentialed within a day. And if you've been there already, it'll be quicker. And they don't actually have student badges right now for either of those locations. Halifax, there's a little bit of a hoop to jump through. If you haven't had a drug test in the past 120 days of when you start practicum, you're going to have to get another one before you can start. So that looked like for the 5 students that to Halifax, our cohort 20 is the day I gave them their assignment, I think was on a Friday. I gave them their assignments on a Friday. They had to go by Monday and get their drug test done. They had to agree to this by taking this assignment. They had to agree that it was going to be doable. The consequence would be you'd get down to it and you wouldn't be able to coach till all 5 of them. A few of them didn't do it by Monday, but they were gracious and let me give them the drug test like the day they were supposed to start. It's not ideal. So they're the only ones that have that rule, though. It has to be 20 days. But the people that went to Halifax, all the locations had a phenomenal experience. Went to the ED at Halifax, Daytona. He did more in, I don't know if you guys know Justin Baggs or talked to him. He did more in his first week in practicum than a lot of students did in 3 weeks of practicum, just because it's such a high volume area. So that's something else to think about, if there's spots available at Halifax and there's not a whole lot of people taking Halifax, chances are you're going to get one of the better spots at Halifax if you're willing to drive there for the 12 shifts. Port Orange is real easy to get to off of I-4. It's just I-4 to I-95 south to Dunlawton is right on Dunlawton. If you're not familiar with the area, it's a real easy drive. Halifax Deltona is right off the Orange. It's 5 minutes from Advent Health Fish. Okay. If you guys have any questions about locations of anything on the wish list, you can just put it in maps and find it. And it'll kind of tell you, like I had one person that was living in Melbourne last time, and she chose Halifax Daytona and was upset because I put her at Port Orange, but when she mapped it, it was actually shorter for her. She just wasn't real sure where that was. So, just kind of look at it. Let me know if you have any questions. All right, so I guess I'll see you guys on Monday then. Okay? Very good. Any other questions for right now?
Thank you.
I have
You're
a question.
welcome. Dr. Green, you there?
Yeah, I think you had one more question.
Yeah. Are we limited to the amount of shifts we're allowed to work per week? Like if our preceptor wants to pick up like overtime, are we allowed to do 4 shifts in a week, or do we have to stay under 40?
That's a really good question. You don't have to stay under a certain number of shifts a week, but you can only work 3 shifts in a row. So some people make their schedule so it's work 3 days, 1 day off, work 3 days. You could actually do that and get 6 shifts in 1 week. But I don't recommend it. So if you're, let's say your preceptor picks up an overtime shift, as long as that overtime shift doesn't make you work more than 3 shifts in a row on either side before or after their overtime, you can do that. And
Okay,
there's
thank
no,
you.
you don't have to stretch it out over the whole 5 weeks. If you can get your shifts in with your preceptor, if their schedule is set up, so if you can get all your shifts in 4 weeks, that's fine. We've had people in 3.5 weeks get all their shifts in. But I mean, that was just because their preceptor's schedule worked out perfectly for them. You know? Okay. All right. Thank you for your time. Thank you, Dr. Green, for your class time.
You're
See you
welcome.
later. All right. Bye.
Thank you.
Guys, why don't you take a break, please, and be back at 3 for our speaker. If you have not taken the time to read the information about Prader-Willi disease in modules, please do it and come with some questions. And this talk is going to be on the finals, so make sure you're taking notes when we come back together. Okay, so come on back at 3 o'clock.